Hello again. We're going to now talk about the echocardiographic identification and characterization of another specific clinical disease state. This time we're going to be talking about hypertrophic cardiomyopathy. Just like with the other disease-specific didactics, um, the identification diagnosis of HCM in this case, again, doesn't strictly fall within the purview of the intensivist. But number one, being able to identify the disease state will clearly have direct implications on your hour-to-hour, day-to-day management of your critically ill patient, especially if they're in shock. And number two, just like with other similar didactics like aortic stenosis, um, this echocardiographic identification of HCM takes these skills and knowledge that you already have, and allows you to apply them in a different way, a different context. So with that, let's talk about HCM. As you know, HCM is a disease state that has been really evolving in our understanding, in its epidemiology and its genetics. The state that it is in now, as far as understanding goes, is that we know that there are several possible mutations that result in the genotype of HCM, and there is inconsistent expression of that genotype into the phenotype of HCM. And even those that have the phenotype of HCM don't necessarily have the clinical manifestations of HCM. So that general incidence that we talk about of 1 in 500 is probably a significant underestimation of those that have the clinical condition, or have the phenotype, I should say, and very much so an underestimate of those that carry the gene, that carry the genotype. So there's probably going to be more and more that we understand and learn about the condition. And its discovery, especially in patients who become critically ill, may be something that we see more and more often. The phenotype of hypertrophic cardiomyopathy basically results in marked asymmetric hypertrophy of the LV. And as you know, there's several variants of HCM, but the majority of the variants, the majority of the phenotypes result in asymmetric hypertrophy that involves the septum. And here is a graphical representation of the four, fairly well understood variants of HCM. They range from, sigmoidal to reverse curve to what we call neutral HCM. These three variants, as you can see, involve significant hypertrophy of the septum. Um, about 10%, maybe even less than 10% of the cases of HCM involve the apex, what we call apical HCM, where the septum itself is less involved, and whereas the apex of the heart tends to be more involved. And so if you look at these variants, those that involve the septum are those that are going to probably, or more likely than not, manifest the clinical findings, the clinical presentation of HCM, rather than those that do not. Okay, so the majority of these variants, like I said, do involve the septum. So septal hypertrophy is the thing that we're looking for if we have a clinical suspicion for HCM. As you know, the pathophysiology of HCM can be described in two words: dynamic obstruction. This is basically obstruction of the LV outflow, the LV cavity, which evolves throughout systole. And like I said, this is especially the case with basal HCM, or the HCM variants that involve the septum, especially the septum at the LVOT, or containing the LVOT. And as you already know from your studies in medical school and residency, this pathophysiology, this dynamic obstruction, is exacerbated by things like tachycardia, hypovolemia, vasodilation, or anything that can cause a hyperdynamic state. Um, as you know, if you're lucky and have HCM, you'd present with heart failure or with angina, or with syncope. And of course, if you're unlucky, you present with sudden cardiac death. But we're here more to talk about the echocardiographic findings in HCM. And so these are the 6 cardinal findings that you, with your current skill set as an intensivist, can apply to arrive at the diagnosis of HCM, and to some extent, get an idea of how severe the disease state, the pathophysiology is in your particular patient. So I'm going to be reviewing each of these in sequence. So the findings that we're looking for, the findings that we can identify with the skill set that we already have include asymmetric hypertrophy of the LV, systolic anterior motion of the mitral valve, mitral regurgitation, turbulent flow within the LVOT during systole, late peaking of the LVOT flow velocities, and elevated left ventricular filling pressures. Okay, so we're going to talk about these in sequence. And like I said, all these things you can identify using your current skill set and your current knowledge set. So first, let's start by talking about the hallmark finding in HCM, which is asymmetric hypertrophy. Uh, Currently, it is thought that, or it is pretty much understood, that HCM, this asymmetric hypertrophy, refers to thickness of the septum that's out of proportion to the thickness of the other walls, or hypertrophy of the septum out of proportion to the other walls. So if you take the septal thickness and you index it to the thickness of the opposite wall, so if we're in the peritoneal long axis view, for example, and we're looking at the anterior septum, and we compare that thickness to the thickness of the infralateral wall, which is the opposite wall, if that ratio is more than 1.5, then you should have a high suspicion that this patient has HCM. So that's essentially the hallmark, at least anatomic diagnosis of HCM. This is best measured in one of the two peristernal views. And that's because in the peristernal view, the probe is closest to the heart when compared to any other transthoracic view. You want to measure it either in the peristernal long view, making sure that you are on axis. So if you don't remember what that is, please go back to that basic view lecture and remember what on axis means when we're talking about the peristernal long axis view. Or you can measure in the peristernal short axis view. Again, you want to be on axis. You want to measure the thickness in diastole. And like I said about 7 times already, you want to make sure that you are getting it, you're making those measurements in an on-axis view. Because if you're off-axis, more likely than not, what's going to happen is you're going to be cutting through obliquely through the heart, and you're going to be cutting through more of the muscle and less of the chamber. So it's going to result in a thickness measurement that may be overestimating the actual thickness. So making sure that you're on axis is very important. Here is an example of a peritoneal long axis view where the septum here is, you can see, much thicker than the opposite wall. So there's asymmetric hypertrophy, in this case involving the septum, including the LVOT. In the short axis view, you can see similar asymmetric hypertrophy. In this case here, there is the septum, anterior septum, inferior septum. You can see here there's a measurement being made of the anterior septum, and it's being compared to the thickness of the opposite wall here. And you can see it's a thickness of 2.3 centimeters versus a thickness of 1.3 centimeters. So that ratio is quite high. So this meets the anatomic criteria for the diagnosis of HCM. But we're intensivists, right? So we're more concerned about physiology and pathophysiology. Does this patient have the pathophysiologic manifestations of HCM? Because that's what's going to be relevant to our care and to the clinical evaluation of our patient, the clinical evolution of our patient. So the sine qua non finding of hypertrophic cardiomyopathy physiology is what's called systolic anterior motion of the mitral valve. So what happens essentially is that the mitral valve, when it's closed in systole, moves anteriorly into the LVOT during systole. And it's thought that there's two sort of mechanisms by which this pathophysiology happens. One is what's called the Venturi effect. The Venturi effect is the direct result of this. You can see this sudden narrowing in the caliber of the LV cavity when you hit the LVOT. So you can see here the septum is quite thick here, much thicker than it is anywhere else. So what happens is, as blood is being pushed from the center of mass of the LV cavity through the LVOT, it runs into a sudden narrowing. So the heart being a closed system, flow throughout the heart is constant. So if you reach a point where the caliber of the flow, of where the flow is going through, suddenly narrows. Because flow is preserved, what has to happen is velocity has to go up. So what happens as you reach this sudden narrowing is you get a sudden acceleration of flow of blood from the main body of the LV cavity as it hits the LVOT. So you get a sudden acceleration of blood through the LVOT, and that sudden acceleration of blood creates a low pressure area right where that acceleration occurs. And as you know, Ohm's law, Bernoulli's principle, what's going to happen is if you have an area of low pressure compared to an area of high pressure, stuff is going to go into the area of low pressure from the area of high pressure. In this case, that includes the mitral valve. Because the acceleration is occurring here, the low pressure area is being created here. There's a significant pressure gradient being created here, and that lifts up the mitral valve into the LVOT. Okay. And this lifting, this anterior motion progresses through systole. So the more systole progresses, the higher and higher that mitral valve is lifted into the LVOT. Again, dynamic obstruction. Okay. This is probably the effect that predominates early in systole. As systole progresses, what happens is you start to get flow drag underneath the mitral valve, which actually pushes the valve upward. So both of these effects, the Venturi effect, lifting or sucking the valve up into the LVOT, in addition to the flow drag effect, pushing the valve up, is what results in the systolic anterior motion of the mitral valve. Okay. Now, how do I identify it? It's best done in the peripheral long axis view. If it's bad enough, you will be able to see it in 2D. But really, the way to identify it is by using M mode, because that's the best way in echo to be able to identify motion occurring over time. M mode is the best mode for that. So what we do is we go into our peripheral long axis view. We take our M mode and we take it down through the septum, down through the LVOT, and most importantly, down through the leaflet tips of the mitral valve. Okay. And we hit start on our M mode. And what we're going to see in a normal heart, a normal mitral valve, is motion that looks like this. So if we look at the structures that the M mode is going through, it cuts through the free wall of the RV here, the RV chamber here, the septum here, the LV cavity, which is here, and this thing fluttering around is the mitral valve. You have the anterior leaflet here and the posterior leaflet, which is tough to see down here. So we're paying attention to the anterior leaflet. So what happens is during diastole, the mitral valve opens, and so the anterior leaflet moves anteriorly up into the alveoli. That's normal. That's happening when blood is being pushed from the left atrium into the, I'm sorry, sucked from the left atrium into the left ventricle. That causes the mitral valve to swing open and that anterior leaflet to go up. Okay. You get a little bit of a pause here in what's called diastasis. The mitral valve sort of half closes. Then you get the atrial kick. Oops, you get the atrial kick, and the mitral valve gets pushed up again. So in sinus rhythm, you sort of get this rabbit ear or M-shaped movement of the anterior leaflet of the mitral valve in diastole. And in systole, the valve snaps shut, as you can see here. So what should happen is in diastole, you get this opening, and in systole, you get this closing. When the mitral valve is closed, it should either be somewhat of a flat line or a gradually ascending line until the valve opens again. Okay? So open, closed, nice and flat. That's normal. Now, when you have systolic anterior motion, it's going to look like this. So this is when the mitral valve is open, and this is when it's closed, but then you can see this being systole, this valve now is being lifted up. The anterior leaflet in particular is being lifted up into the LVOT. And that is anterior motion of the mitral valve, or SAM. Okay. And as you can see, as systole progresses, that valve gets sucked and pushed up further and further and further into the LVOT. And then you can see the resultant size of that LVOT becomes really, really small. So you can visually see this dynamic obstruction happening. And a big cause of that dynamic obstruction is the actual systolic anterior motion. Okay. The other thing that you notice is like we said before, this is the anterior leaflet, it's the posterior leaflet. You can see that as the anterior leaflet is being sucked up, it's actually being pulled apart from the posterior leaflet. So what's happening here is you're getting insufficiency of the mitral valve. Keep that in mind. We're going to talk about that later. Okay. But this is what systolic anterior motion looks like. When the valve is supposed to be closed, you get this little hump here of the anterior leaflet being sucked and pushed up into the LVOT. So this is SAM. This is actually something that will probably show up on your critical care boards as a sine qua non finding in hypertrophic cardiomyopathy. Okay. So like we saw right here, one of the consequences of SAM is mitral insufficiency, as the two valves, when they're supposed to be closed, are being pulled apart. And so the result of that is mitral regurgitation. So like I said, mitral regurgitation in this case is a direct consequence of SAM. The severity of the SAM is directly proportional to the severity of the obstruction. Because again, the more acceleration of flow you get, the more that pressure gain is being created, the more that flow drag is being created, the worse the SAM is. So the worse the obstruction is, the worse the SAM is, the worse the SAM is, the worse the mitral regurg is. So in many ways, the degree of mitral regurgitation can be looked upon as an indicator of the severity of the dynamic obstruction. Okay. So this is a functional regurg. There's nothing structurally wrong with the valve. It's being functionally made insufficient by that systolic anterior motion. So usually functional mitral regurgitation is eccentric. Means it's being directed in one direction, usually posteriorly. So that's the mitral regurg you're going to see in the setting of HCM is posteriorly directed mitral regurgitation. So here's a still picture of that. This is a peritoneal long axis view. Here's the mitral valve. This is supposed to be systole, and you're seeing a regurgitant jet of flow being pushed down to the posterior wall of the left atrium. Here's that same patient apical four-chamber view. You can see much more clearly that mitral regurg. You can see it's being directed posteriorly. And again, this is a functional regurg occurring because of the systolic anterior motion of the mitral valve. Okay. The third finding, I should say fourth finding, echo finding in HCM, is turbulence of flow, systolic flow through the LVOT. So normally, because the LVOT normally is a pretty large caliber sort of structure in the heart, anatomic location in the heart, during systole, normally the flow through the LVOT should be laminar. But if you get abrupt narrowing of the LVOT like you see with HCM, what can happen is that laminar flow can quickly turn turbulent. And again, that's all because there's that, again, sudden acceleration of flow in the LVOT. So what happens is laminar flow turns turbulent. And again, all the things that exacerbate the dynamic obstruction will make the turbulence worse. Okay. So here is a video of what normal systolic flow through the LVOT should look like. So when you're doing color flow Doppler, remember that single color indicates laminar flow, single direction flow. Multicolored flow is multidirectional or turbulent. So you can see this is what's happening here. This is normal, is that as blood's being pushed through the LVOT in systole, you get laminar flow. It's all one color, it's all blue. And it's all laminar until it hits the aortic valve. And then when it hits the aortic valve, which is an area of abrupt narrowing, then you get turbulence downstream of the aortic valve. That's normal. You should not see turbulence here. In HCM, what happens is because there's abrupt narrowing at the LVOT, so here's the aortic valve, here's the peritoneal long axis view. Aortic valve is here. This is the LVOT. This is a still picture of flow through the LVOT, and you can see that before it hits the aortic valve, the flow is already turned turbulent. Okay, and that's not normal. One of the things that can do this, like I said, is if there's obstruction here, either sudden narrowing caused by LVOT obstruction, by HCM, or some sort of abnormal growth or vegetation or something like that can cause turbulence there as well. Or if you have a hyperdynamic circulation, like in the setting of, vasodilatory shock, pheochromocytoma, sympathomimetic drug toxicity, that kind of thing. That can also produce very high systolic velocities just because the heart is just so hyperdynamic. Okay, but if you have the anatomic findings of asymmetric hypertrophy plus turbulent flow in the LVOT, that is indicative of HCM pathophysiology. Here is a nice picture here, apical 5-chamber view of systolic flow. The aortic valve is way down here. And you can see here just how thick the septum is. So in systole, turbulence is starting way up high in the LVOT. You can see this flow is turning turbulent way before the aortic valve. So this is turbulent flow in the LVOT during systole, shown the apical 5. Here is another interesting view where you see both the turbulent flow through the LVOT as well as the mitral regurg. Okay, so thus far, everything we've talked about in terms of how to identify HCM pathophysiology has been straight qualitative two-dimensional echo. We talked about finding asymmetric hypertrophy, using M-mode to find systolic anterior motion, and using color flow Doppler to find mitral regurgitation and turbulent flow in the LVOT. So thus far, this has all been qualitative assessments. Okay. Now we start moving into some quantitative findings, some quantitative Doppler findings of HCM. The first and probably the most important finding in HCM is what we call late peaking of the LVOT flow signature. So what should happen is, let's say you are in your apical 5-chamber view and you do your pulse wave Doppler through the LVOT. You know what that's supposed to look like. It's supposed to look like rapid linear acceleration to a peak velocity and less rapid deceleration to the end of systole. It should look like a knife, like a chef's knife, I guess. Okay. With HCM though, because you are getting this, you have this obstruction, the obstruction results, like I said before, in rapid acceleration of blood flow through the LVOT. So all of a sudden you get this sudden acceleration, but that acceleration takes a while to happen. So what you see in the flow signature is late, abrupt acceleration of flow velocities through the LVOT during systole. Okay. The best way to identify this is by using continuous wave Doppler through the LVOT. So this is how we do that. And we use continuous Doppler for two reasons. One, because we're probably dealing with fairly high velocities. And number two, we may not know exactly where the narrowest point in the LVOT is. So putting continuous wave down through there will help us find, the flow signatures everywhere along that line. And the ones that it's going to present will be the one that is at its most narrow point. So continuous wave Doppler, apical 5-chamber view, and we get a tracing. So this is what it should look like normally. And this should look familiar to you. This is a normal sort of velocity time curve. But since we're using continuous wave Doppler instead of pulsed wave Doppler, you can see that it's all filled in. Because we're getting every single instantaneous velocity along that line. But the shape should be like this, normal. Rapid linear acceleration to a peak, less rapid deceleration to 0. Looks like a regular chef's knife. Okay. What you see in HCM is this. So what you have here, this is the beginning of systole. Okay. So what you have here, it takes a little while for the velocities to go up, but then all of a sudden you get this abrupt acceleration to a peak and then a rapid deceleration to end of systole. Okay. Some have described this as an icicle shape. Some have described this as a dagger shape. There's one cardiologist back in the day who thought this looked like an Arabic war dagger called a khanjar. So he called this the khanjar sign. At any rate, what we're looking at is late, abrupt acceleration of LVOT velocities in systole. Okay. Interestingly enough, it also looks like the deep, narrow Q waves that you see in HCM on EKG. Physiologically, they're not related at all, But interestingly enough, it looks like those Q waves. But Kunjar sign or dagger-shaped LVOT flow signature is characteristic of HCM pathophysiology. Okay. The other thing you can see is high cavitary pressure gradients. What that basically means is um, you generate pressure gradients. Again, Ohm's law. Pressure gradients are generated either in areas where there's high flow or in areas where there's high resistance, right? Because there's resistance across the LVOT through the aortic valve, normally what happens is the pressure gradient that we find is at the aortic valve, is at the narrowest point, which is the aortic valve. However, in HCM, because you get abrupt narrowing of that caliber in the LVOT proximal to the aortic valve, what you will see is you will actually see pressure gradients in the chamber of the LVOT, of the LV/LVOT, instead of at the aortic valve. Okay, so what that is called is cavitary pressure gradient. So normally through the LV cavity, there should not be significant pressure gradients because there's not significant narrowing of the caliber of the LV until you reach the aortic valve. But if you have HCM, that sudden narrowing is occurring actually in the cavity of the LV in the LVOT. So what you'll find is you'll find pressure gradients that are elevated in the LVOT. Okay. If you identify a pressure gradient, a peak gradient in the LV of more than 30 millimeters of mercury, then that is highly suggestive of HCM. Okay. So the way we identify that is by using pulsed wave Doppler. And we're trying to find a place anywhere between the aortic valve and the main body of the LV where there's an elevated pressure gradient. Okay. So what we do is we do pulse wave Doppler, and we start with that velocity sampling gate just above the aortic valve, just like you would do if you're measuring stroke volume. Okay. And you would start your Doppler tracing. Then what you do, you sort of measure out your velocity time curves, or let them sort of go beat to beat. And then progressively, you're going to grab this velocity gate and gradually move it upward, higher and higher into the LV cavity. And if you move it and you find a place where the velocity, the peak velocity and the velocity time curve skyrockets, then that's where there's going to be an elevated pressure gradient. Okay, so keep moving it up until the velocity time curve shoots up. Freeze it, and you're going to measure the peak velocity, and that peak velocity measurement will give you the pressure gradient. And if the pressure gradient anywhere here above the aortic valve is higher than 30, then that's suggestive of elevated intracavitary pressure gradients and HCM pathophysiology. Okay. The one limitation of this is if you're using a point of care machine, oftentimes the velocities that you get when you have an elevated pressure gradient may exceed the velocities that are able to be measured using pulse wave Doppler for our point of care machines. So what may happen is you may get a velocity curve that goes off the scale, in which case you won't be able to specifically measure it, but at least you can say, oh man, those velocities are super high, and I am above the aortic valve, and that is abnormal. Okay. So finally, the sort of end state finding in HCM using POCUS is the identification of elevated filling pressure. So what's happened is over time, the LVOT has become obstructed. You've had this pathophysiology of impaired forward flow. And eventually what's happened is LV filling pressures start to increase. And you develop essentially diastolic dysfunction as a result of either long-standing or severe HCM. Sort of like the final common pathway. Okay. So while elevated filling pressures are not specific to HCM, if you have HCM and you identify elevated filling pressures, that's kind of bad. Okay. So this is essentially an extension of or utilization of the modalities that we use to identify LV diastolic dysfunction, and we're applying it to a patient in whom we think there is HCM pathophysiology. Okay. And what we're trying to do is we're trying to identify or trying to measure the E to E prime ratio. So I'm not going to belabor this too much because there's a separate lecture on this. But what we do is we take two measurements. We measure mitral inflow velocities. So apical four-chamber view, pulsed wave Doppler with the Doppler volume at the mitral leaflet tips. And we're looking at diastolic velocities here. So if you're in sinus rhythm, you should see an E wave correlating with passive filling of the left ventricle in early diastole. You get a bit of a pause correlating with diastasis, and you get a second wave called the A wave correlating with the atrial kick. Okay, these are blood flow velocities. So this first one is the E wave, and we want to measure that. Then we take tissue Doppler and we measure the velocities of the mitral annulus, the lateral mitral annulus in diastole. And similar to blood flow velocities, you get an E and an A tissue velocity. So E prime is the tissue movement that occurs during the E wave during early diastole, and the A prime is a tissue movement that occurs during the atrial kick. So what we would essentially do is we'd measure the E velocity and measure the E prime velocity. And if that ratio is more than 15, then that is indicative of elevated left ventricular filling pressures. Kind of bad in the setting of HCM. Okay. So to summarize, these are the six cardinal findings that are usable, that are doable by someone who has the skill sets and knowledge set that you already have. We talked about identifying asymmetric LV hypertrophy, systolic anterior motion of the mitral valve, mitral regurgitation, turbulent flow during systole in the LVOT, late peaking LVOT flow signatures, and elevated left ventricular filling pressure. Again, how is this relevant to critical care? Like I said, it's not your job per se to diagnose HCM, but being able to identify the pathophysiology, again, is going to have direct implications on what you do with things like volume, heart rate and rhythm control, induction, sedation, vasodilators of other types, that type of thing. So knowing that it exists is going to help your clinical management, okay? And if you identify these things, again, get the formal echo to confirm the diagnosis and further characterize what you're dealing with, okay? The other thing to remember is, if you remember back from the quantitative LV didactics, we talked about how the only way to use LVOT VTI to approximate the stroke volume is for number one, the LVOT, the shape of the LVOT has to be cylindrical, one. And number two, the diameter of the LVOT shouldn't change throughout systole. And if you have HCM, both of those rules have been violated. So if you have someone with HCM, you cannot use LVOT VTI to help you estimate the stroke volume. Okay, so this is going to affect what you can and can't do in terms of measurements in someone who has this pathophysiology. All right. Well, if you have questions, you know how to reach me. Otherwise, I look forward to scanning with you.